Good evening, everyone. My name is Yashodhan Brahme, and I'll be presenting today's long case for today's Thursday clinic. So, my child is a 2-year, 2-month-old male child who's second by birth order, born of third degree consanguineous marriage, who's a resident of Nashik, and he's also hailing from Nashik. He's Muslim by religion, Sheikh by community, and he's brought by and his informant being mother with chief complaints of icterus jaundice on and off since 1 year and abdominal distension since 1 year. So this child, around 1 year ago, the mother noticed that the child has developed yellowish discoloration of eyes, ears, and face, along with high colored urine, which progressed gradually over a period of 1 week. This icterus or yellowish discoloration was only noticed up till face and neck, and it was not involving the limbs and the body. On probing, there is history of high colored urine, but there is no history of pale colored stools. And there are no other symptoms reported. The child was otherwise active and feeding well during this course of the illness. For these complaints, the child was admitted in a government hospital in Bihar, and some investigations were done and some treatment was given. The details were not available, and no blood transfusions were given at that time. The parents were counseled that the child has some liver swelling along with jaundice and was discharged on some oral medications. This icterus gradually resolved on its own over a period of 1 month. The child was asymptomatic, well
Yeah.
feeding, and active at home for around 1 month. And when the mother realized that the child has abdominal distension, this abdominal distension has been chronic, has been insidious in onset. It has been gradually progressive over the last 1 year, and it is more involving the upper part of the abdomen than the lower part. It is not associated with periorbital or pedal edema. There are no diurnal variations, and there is no breathing difficulty reported along with this progression of swelling. The child again developed another episode of The child again developed another episode of jaundice of similar semiology and progression. This time, the child was given some homeopathic treatment for few weeks, and the jaundice resolved on its own after a period of 1 month. But the abdominal distension persisted and gradually increased. Some investigations were done from a private hospital at that time, and which were told to be normal. 2 months ago, this child had two episodes of paroxysmal event. The first episode is when the child was playing on his own prior to this episode, when the mother noticed there was sudden tightening of all four limbs, along with uprolling of eyeballs, with frothing at mouth, which lasted for around 2 to 3 minutes, and it subsided on its own, followed by a period of drowsiness for around 10 minutes. The second episode happened on the same day, a few hours later in the evening, which was of similar semiology. There's no history of fever, trauma, lethargy, irritability, or refusal to feed prior to this episode. The child was taken to a local hospital and some neuroimaging was done, which was told to be normal. And the child was started on some anti seizure medications on discharge after 2 days, which the child is taking regularly. And there have been no repeat such episodes since then. For above complaints, the child was brought to Sion for further evaluation and management. On inquiry, the mother has also noticed that there is delayed achievement of milestones in her child as compared to his elder siblings and his peers. The child has been otherwise well and active at home and feeding well since the onset and the course of the presenting complaints. There is no history of fever. There is no history of rash, eyes, or ear involvement to rule out congenital infections. There is no history of blood transfusion in the child or the family. There is no history of gallstones in the family members to rule out hemolytic and hematological disorders. There is no history of constipation, lethargy, or poor feeding to rule out congenital hypothyroidism. There is no similar family history, and there has been no history of bleeding manifestations, vomiting, or poor feeding to rule out any significant organ dysfunction. Starting with the ANC history, this was a spontaneous conception. She was registered at a local government hospital. She has taken IFA tablets and 2 doses of injection TT. Two ANC scans were done and they were told to be normal. There is history of pregnancy-induced hypertension in 8 months of ANC. She has taken some treatment for 1 week and then she was advised to stop on follow-up. There is no history of blood transfusions. There is no history of fever with rash. There is no history of hypothyroidism or gestational diabetes or any other medical illnesses during the pregnancy. This was a full term normal vaginal delivery. The child cried immediately after birth, and the birth weight was 2.5 kilos. There is no history of an ICU stay. There is no history of a neonatal jaundice, and the child was discharged on day of life 2 on exclusive breastfeeds. The child was active and feeding well on discharge. The child is immunized till 9 months of age as per national immunization schedule. Going to developmental history, gross motor wise, the child can sit without support. He has achieved this by 9 months of age, but he cannot stand or walk. The fine motor wise, the child has developed mature pincer grasp by around 18 months of age and can now scribble if given a pen to hold in his hand. Uh, in terms of language, the child can only speak in bisyllables. He waves bye bye and he comes when he's called. He fixes and follows, and he responds to auditory stimulus and he responds to his name. So there is developmental delay in 4 domains. So the child has global developmental delay. Dietary history wise, he was exclusively breastfed till 6 months of age, and the weaning started at 7 months. It was faulty weaning, which was started with biscuits and bottle feeding, and gradually the child was shifted to the diet that the family has. But it is still deficient in calories by 301 kilocalories per day, and it is deficient in proteins by 7.8 grams per day. The child consumes 5 out of 7 food groups. There is no history of similar complaints in family members, and the child has an elder sibling, a 5-year-old female child. She has been alive and well, and there is no significant medical history in his elder sibling.
So this is a 2-year-old child who's come with a history of first episode of jaundice at about 1 year back. So roughly the child must have been, let's say, 1 year at that time. And the jaundice is yellow discoloration of eyes along with high colored urine. So what is your analysis of this episode? So first question is, what kind of jaundice is this? Conjugated, unconjugated?
Conjugate.
Why? You're right, but tell us why.
Because child is passing high colored urine.
Very good. So child is passing high colored urine, so it's conjugated jaundice. So now my next question is, the commonest cause of conjugated jaundice is viral hepatitis in practice.
Yes.
So is this viral hepatitis? On first others, then take the mic and speak in the mic.
There are no prodromal symptoms prior to the
Okay.
onset of jaundice.
So we need to confirm whether there are prodromal symptoms. So you're making a point that viral hepatitis is usually associated with prodromal symptoms, but anything else?
We are early age group.
Very good. So 1 year is a very odd age for viral A hepatitis. Anything else? If you do get viral A in young children, is there a little variation in clinical presentation? It can be even anicteric. Okay.
If diarrhea occurs in infancy, far more common. Okay. It's an orally transmitted infection. Viral A is also orally transmitted infection. Why should it not be common in that age? In fact, diarrhea is far more common at that age than later age. What do you think must be the cause? Give a thought. Doesn't matter. Okay. So I'll give you a clue. Is the infection not at all possible? Answer is no, it's possible. That means at that age, the host does not react. Subsequent age groups react. Okay, that's why we say, oh, it's not seen. If if you have an infant to whom you fire, he must be wondering what's wrong with his parents. He won't cry, he won't protest, he may laugh. Why are you shouting? Okay. Response is different to even illnesses. So the point is that the responses to some of these viruses are such an extent that either they have an asymptomatic infection or a very unusual presentation which is not even picked up. And I think that is important. Okay, could a maternal transmission of antibodies protects that age? Measles, yes. Okay. So do you think virally will have a maternal antibodies which will protect the child for a while? What do you think about it? Just give a thought. I mean, this is the way you start thinking to learn medicine. Okay. What do you think? Come.
So, so for all maternal antibodies, one other way to look at is that when do you give that vaccine? If you have to give a vaccine. So when is hepatitis A vaccine supposed to be given as per the current schedule?
12 months.
12 months. So that means if it can be given at 12 months, that means definitely at 12 months, the maternal antibodies cannot interfere. That's why you're allowed to give it at 12 months. Okay, fine. So that's about maternal antibody. So we have discussed that you start thinking that even though this is a conjugated jaundice episode at 1 year of age, for reasons which we discussed, no prodrome, odd age, we are not thinking of this as a viral hepatitis. So now next, what can it be? So can it be a hemolytic anemia?
I think once you decide it's a conjugated bilirubin, the first thing is it a hepatocyte or a biliary tract? And then you branch out further. What do you think this must be? We don't know anything further. We're just discussing the slide shown to us now. So do you think it's biliary tract disease or a hepatocyte disease?
How do you normally differentiate between the two?
So we differentiate on the basis of sick and non-sick. So if it is hepatocyte involvement, because it is a focus of major metabolism, if there is hepatocyte affection, the child will be overall sick. There will be reduced appetite. There will be refusal to feed. There will be irritability, vomiting. Whereas a biliary tract pathology, the child will be otherwise well and active, but will have a deeper jaundice. So this child has been otherwise well and active at home. It is just that the mother has noticed that the child is developing interest. That's why she has seek medical treatment. Otherwise, the child has been fine. So more in favor of a biliary tract involvement than hepatocyte involvement.
The biliary tract, you are right, has much severe jaundice, disproportionately much reasonable good health. And there is itching too. But this child is still fine, no? So must be biliary only.
Yeah, so he's saying this looks like biliary.
Yeah, but where is severe jaundice? Where is itching? So now when there is a discrepancy like this, what can decide right at this stage whether we are looking at hepatocyte or biliary tract? Itching is difficult at this age to pick up. It will be seen only as irritable child. This child is not even irritable. Okay. So probably there is no itching. What else do you want to know? And therefore you want to pick up whether there is a severe jaundice and then clay colored stools. So that's another. And the next thing is there an abdominal distension? Abdominal distension is not biliary tract disease. Abdominal distension is hepatocyte. And therefore, in a biliary tract also you will get abdominal distension. No? Why? I said loudly, biliary tract, no hepatomegaly.
So understand Sir's statement properly. First, Sir said that in biliary tract there is no abdominal distension. And then Sir said in your classic biliary atresia, you do get abdominal distension. So what is the explanation? Come on, come on.
Once the biliary tract disease is severe enough, that can cause cirrhosis, and the biliary atresia itself, when gets severe enough, it destroys the hepatic architecture, that then leading to ascites and
Very
abdominal
good.
distress.
And therefore, unless hepatocytes are involved, you don't get hepatomegaly in a biliary tract. So if there is an abdominal distension,
It came up later
Came up
after
later.
this
fine.
episode.
So at that stage, if you saw, you are talking about near asymptomatic child, accidentally noticed jaundice by the mother, and then the child is absolutely fine. What must be the pathology and what must be the etiology? What are the pathologies? Inflammation, common pathology. Can it be inflammation? Then we will say infective or not infective. Could there be an inflammation in this child? So what are the symptoms of inflammation?
Fever, very good. Fever. What?
Fever. Pain.
Pain. So these two are not there in this child. What else? Loss of function. Very good. Okay.
So now the question is that if you feel there is no abdominal distension, but there is no severe jaundice, it's not progressive, there is no itching, so you are not very certain where we are. Okay. So now we start thinking, can it be an asymptomatic biliary tract disease? Or could it be an asymptomatic hepatocyte disease? What do you think between the two? Who could be asymptomatic? Who could be healthy? Who could be doing well? And not just well, continue to do well. So first and foremost, this was seen at 1 year. Now, 1 year is too long a period for mother to have missed it. So we believe that it must not have been from birth. And certainly if it was from birth, it was not progressive. Okay. So could it be enzyme deficiency? Rubin Johnson, rotor. Okay. Nothing wrong except jaundice. And coming right from early age or at any age. So I would have thought first whether it's an enzyme deficiency. That means it's not inflammatory. Why not? We said all that. What about chronic inflammation? Yes, chronic inflammation can fool you almost without any significant symptoms of inflammation. But there are subtle symptoms. That means he's a little irritable, he's not feeling well, some changes, but those changes are subtle and could be easily overlooked by even the parents. So chronic inflammation needs to be kept in mind. Enzyme deficiency most likely at that time. Okay, I think that's where we would have stayed on. Okay, and then it starts.
Yeah. So just one sec. So, I mean, we are just trying to refine our history further. That's why I brought this point. After this, you have said that no blood transfusions were given. So I want your comments on that. That why did you that history and what is the thought behind that? So would you consider hemolytic anemia in this child? A 1-year-old child who has come with this kind of a jaundice, would you consider hemolytic anemia?
You can consider in case of THAL if at undiagnosed hemolytic jaundice. History of blood transfusions might be there.
No, in case of THAL, history of blood transfusion is there. But in case of THAL, what is the presenting complaint?
Abdominal distension.
Or pallor. Okay, progressive pallor. Secondly, what hemolytic anemia is what type of jaundice?
Unconjugated.
Unconjugated. You've already said this is high colored urine. So you're not considering hemolytic anemia here at all. So therefore, you may even skip that history that no blood transfusion given. And if as an examiner I ask you, you should say that, sir, there is history of conjugated jaundice. So it's not one of my DD.
Is it likely that the blood transfusion given, for whatever reason, has passed on a virus into this baby? And now you have a hepatocyte disease. What do you think? So which virus can go through blood transfusion because it is not checked? Hepatitis B is checked now. Okay, HIV is checked.
Histosome. Histosome.
Okay.
CMV, what else? So of course, nowadays we check for hepatitis C also, but earlier hepatitis C was 90% through blood transfusions, right?
Hepatitis C is often not checked while giving a blood transfusion. Hepatitis B is checked. So hepatitis C can go through that. CMV can go through that. Okay, CMV is not an uncommon disease in the population, and many may have been asymptomatic.
To continue where sir was asking what kind of a disease this is likely to be. So you discussed that it is not inflammation. Okay, the jaundice coming up that way. What else? So as a principle, what kind of diseases come up suddenly, stay for a while and then suddenly go away? What kind of such diseases? Come on. Are they inflammatory? Are they degenerative? Are they infiltrative? Are they metabolic? Are they, what kind of disease are they? Vascular? What kind of disease?
Immunological.
Immunological or metabolic. So in relation to a liver disease, you would put metabolic higher than any immunological damage. So point is that with this kind of a history, after the first episode, you start thinking whether this is a metabolic disease. Okay. Can it be Wilson's? Sorry. Can it be Wilson's?
Age of presentation is 1 year. So it's like less likelihood.
So what age do you want?
Within 3 years after which we started earlier.
So earlier we used to say 5 years, then we've come down to 3 years. There are lots of mutations being discovered in Wilson. So now you know that some mutations are affecting the function a big deal, some are affecting a small deal. So you can have younger children, but not as young as 1 year old.
Sorry, I am just trying to revise as we just bifurcated based on the color of urine, conjugated, unconjugated, and we came to the diagnosis of unconjugated nahi hai. That means conjugated, that means hepatocellular or obstructive. Now, between the two things, I thought that obstructive coming for the first time at 1 year is relatively uncommon because most of the causes of obstructive jaundice come very early in life, even if they are due to inflammation intrauterine. Biliary, biliary tract is due to stone that biliary stone can come little later, but there has to be a history which will make this child prone to that. Sometimes I would have expected in a child who has got obstructive jaundice some color alteration in the stool, though it may not have been completely clay colored in stool. So between the two, also one would rather believe that it is more likely to be hepatocellular than obstructive. And in hepatocellular jaundice, I thought that for that matter, any hepatocellular jaundice must give rise to some sickness. Whether it is infective, metabolic, an absolutely normal child developing hepatocellular is perhaps difficult. So we might have missed on some history where the child was not well. A, we have considered, BC, etc. We have considered is unlikely. Enzyme deficiencies, and as sir said, we have the two different varieties of it. The other rotors and this we don't see that much. We see the other Gilberts and all more commonly. In fact, one of my friends said rotor, only rotor has seen, nobody else has seen. So must be uncommon. So enzyme deficiency, were relatively normal child and the course. So I think even for analysis, we come to hepatocyte disease primarily. Infectious, probably not. Metabolic, but relatively a milder form of metabolic. And as he said, inflammatory is possible. But any inflammation, autoimmune or otherwise, must give rise to a sicker child. So we are coming to metabolic, but we are open to discussion. And this is the first episode, so we are not wiser. As the time goes, we'll be wiser.
I think in the first episode here, we are sure what it is not. But what it is, we don't know. Typically, enzyme deficiency is rare. Crigler-Najjar is not so uncommon. Okay, but certainly, even Gilbert is not so uncommon. But we keep that in mind, or otherwise, a very mild degree of any other disease which could be fooling us. Just to add to what Dr. Khare said, the biliary tract disorders early in life could be paucity of biliary canaliculum. It's a syndromic problem. Second is an acute sclerosing cholangitis, which is like an autoimmune hepatitis. And therefore, we just keep in mind all that. But what he said is absolutely right, that therefore it's a hepatocyte disease. Right?
Okay, now
The jaundice resolving over 1 month is also, can it point towards non-obstructive causes?
yes, when it resolves, yes, but of course there is intermittent obstruction. So technically, this could fit in with a choledochal cyst, where you had obstruction, you had obstructive jaundice, it resolved. It can fit in. So that first episode we can't have a perfect answer, but later, of course, we'll get wiser, right? So now you have a abdominal distension coming up 1 month after this first episode, and it's in the upper abdomen. So what do you all think it is? What do you think it is? Hepatomegaly, right? So you on history analyze that now you've got a hepatomegaly coming up. Okay. And now, so now that hepatomegaly is coming up, my next question to you is, can this be congenital infection? I'm just asking you just so that we start thinking and rule in or rule out. So 1-year-old got jaundice and then hepatomegaly came up. So can it be a congenital infection? What do you think? The mic and try.
Antenatal history we have to ask.
Yeah, we have to ask for antenatal history, but remember, in congenital infection, antenatal history, if it is there, it helps you, it strengthens. But if it is not there, you can't rule it out.
More early presentation will be there.
Okay, more early presentation will be there. What else?
Child will be sick. Sick looking child.
Okay.
The sequence of presenting complaints in congenital infection will be a bit alternate. He'll present with maybe organomegaly or the distension or hepatosplenomegaly, and then along with jaundice or followed by jaundice.
Fine. So one is the sequence. What else? You were saying something. No. How can you have a gap of 1 year? That is most important. No. If it is a congenital infection, we are postulating infection started intrauterine. So for that first 1 year, there has to be something. No, you can't, that infection can't start manifesting after 1 year. Okay. So it's out of question. So now there's another second episode of jaundice, and which is similar. So now what do you think? So you have 2 episodes of conjugated jaundice, and in between abdominal distension has come up.
Now that abdominal distension has come, let us keep our mind open for something which we didn't consider, and that is whether it is pre-hepatic problem, like in the form of hepatomegaly, like Burschiari. Burschiari can come up anytime. It can present as abdominal distension and jaundice in a child who is not very sick at that time. So that also, we don't know whether this jaundice has resolved so far or no. It did resolve later on. So what we had really were not worried about is this, but one does not know whether the sequence was jaundice first or abdominal distension. Perhaps the sequence must have been abdominal distension first and jaundice has not. So we thought of it, and now we are considering that it is not likely. But just not to forget the syndrome of prehepatic obstruction. We just keep that.
What is the other clinical finding which is very common in Budd-Chiari, which is missing here? Ascites, very good. Ascites. Okay. So now this tension, we've not examined. We don't know whether there's ascites or no. But if it's a clear-cut upper abdomen, then it's likely only hepatomegaly and not ascites. Okay. So now, with these two episodes of jaundice, both self-resolving and abdominal distension in the form of hepatomegaly, now what do you think? Before we go to the next symptom.
A progressive disorder now involving the hepatocytes, more extensive damage.
So more extensive damage may not be the right word because see, so for example, let's take an older child with a chronic liver disease. This older child may get jaundice somewhere in between in that long course of chronic liver disease. But what is striking is the other hepatocyte dysfunction. So failure to thrive, poor weight gain, then edema feet, all those things come up. And then somewhere in between, there may be an episode of jaundice, right? So this is not really progressive in that sense. So the pathology is there, but it's manifesting clinically intermittently. So I thought that is strengthening the possibility of this being some metabolic disorder. Okay. Now the next symptom is a paroxysmal event.
What Dr. Rajesh wanted to say was it's an ongoing disease from early life, and jaundice has just been an event in that. And that is why this is the hepatomegaly has come up. So ongoing disease, jaundice one symptom, that it has come and gone tells you that it may come up again also, we don't know that.
What about the seizure now? What do you think? Could be a febrile seizure unrelated to the jaundice. Come on. Who is awake and who is sleeping? Huh? There's no fever, no history of fever. So what is this seizure?
As the jaundice progresses with maybe involvement of the brain.
So in theory, yes, you're right. So you have to ask yourself, has the disease advanced so much that it is now causing a brain involvement? So now you think deeper and tell us that before the disease advances so much to involve the brain, you mean hepatic failure and encephalopathy, right? That's what you're trying to say. So what are the other features here and how do they guide us? Has the hepatic function worsened so much? No, right? So it's not hepatic failure and encephalopathy, right? So there are two seizures, generalized seizures on the same day, and there is no fever, trauma, irritability, lethargy, refusal to feed. So if you were to forget the jaundice and if you were to take only the seizure as it is, how would you describe that seizure? Epilepsy. So would you kind of label it as epilepsy at this stage? So it is a first unprovoked seizure and then the second seizure on the same day, right? So now if you have to connect it with the previous history, then how can you connect it?
Some metabolic disturbance, electrolyte disturbance, or hypoglycemia.
So for things like hypoglycemia and maybe whatever, hypocalcemia, etc., there should be some clinical event which should give us a clue that this happened. So that would fall under a acute symptomatic seizure, which this doesn't seem to be. I mean, it has come out of the blue, right? So if this patient didn't have that previous history, didn't have that jaundice, as we said, we would have just called it unprovoked seizure and seen where it led us to. But since we are thinking of a metabolic disease, you can start thinking of a disease that affects multiple organs. So now it has started affecting a second organ. So that could be a thought process, right?
I think we are sure about the liver disease in this child. Now, how do you connect liver disease to a probable seizure? For example, we said metabolic cause of liver disease. Could there be a metabolic same cause which is causing a seizure? I'll give you an example. You have a carbohydrate metabolism error that has affected the liver, glycogen storage, for example. Now he will have hypoglycemia and he will throw up a seizure, and the seizure will be self-limiting. That will be almost called as an acute symptomatic seizure. But we are not sure, just looking at that, whether it's an acute symptomatic. But if it is related to liver, then the cause of liver disease is the same cause of seizure as well, and therefore you have a hypoglycemia to connect the two. That's one possibility. The second possibility is if it is not acute symptomatic, it's not idiopathic. At this stage, you don't call anybody idiopathic epilepsy, in which case it must be remote symptomatic. And what is remote symptomatic? The brain is already damaged. So at this point of time, in fact, in any disease that is going on for a long time, two important things must be discussed. One, how is the health maintained or deteriorating? So we need to know that. Okay. Second is, how are the milestones continue to be achieved or not? Unless we know that, we will not know the answer to whether it's a remote symptomatic or an acute symptomatic. Okay. Could there be any other disease which has affected the liver and the brain? Again, in metabolic pattern. So I talked about the carbohydrate metabolism disorder and hypoglycemia. Could it be lipid problem which affects the brain and the liver?
Some fatty acid oxidation defects can.
So several disorders affect both Gaucher's, Niemann-Pick's. Okay. But these are not the ones who have that intermittent problem. And therefore, there is a different, many ways of putting liver disease and jaundice to a neurological disorder. So I think we need to know that. You said about some delayed milestone. It will be important to find out since when it is. If it was much before the seizure occurred, it's a remote symptomatic seizure. Right?
Okay, now let's look at the development, and now all of you answer so that you get practice. So gross motor can sit without support by 9 months and does not stand or walk. So Khare sir has made this point so many times that when we give this developmental history, what are the different things that we have to mention? So he started sitting without support by 9 months. Normal or delayed? Delayed. Delayed by how much? You want to sit without support, want him to sit without support by 8 months. So 9 months is nothing great. Okay. So don't jump and call it delay. Okay. So maybe, maybe not types. But then he has not, he does not stand or walk, and he's now 2 years, 2 months. So the point is, over the next 1.5 year, there is no further gain in milestone. So this is called something like developmental arrest. Okay. which effectively means static or progressive? Progressive disorder, right? So maybe if there is more time given, they may actually regress, and whatever is achieved may also go down. Okay, fine. Then fine motor, mature pincer grasp at 18 months. So that is delayed or normal?
When we say that his gross motor was relatively normal as far as sitting was concerned, we don't know the other milestones, but there was delayed standing and walking. Without knowing the other milestones, I would say that he had some problem related to his muscles. He had rickets or some weakness of the muscle or something like that, where those milestones which are not dependent upon balancing or standing are not affected. Well, for example, a ricket child may sit at normal age, but will not stand at normal age. I'm just saying, but once the other things come up, this goes out. So when you have only isolated delay, idea is that when you have only isolated delay in one part of the milestones, especially with no walking, but sitting, then we think of that. This is not applicable to here. What about congenital dislocation of hip? Do they walk on time or they walk late? It's not related to this. One good rule is there. Congenital dislocation of hip is never a cause of delayed walking. They will walk at normal, but they will not walk normally. They'll have waddling. And tongue tie is never a cause of speech. They may have articulation problem, but never delayed speech, because speech is not here. Where is the speech? Speech is here. So when that is not affected, it's sorry for diverting.
So now come to the fine motor, mature pincer at 18 months, normal or delayed? Delayed. Scribbles. So scribbles what? Is that important or not important? So what is the progress of scribbling? Take the mic.
Line by 2 years.
First, what does the baby scribble? Earliest.
Single line. Line.
Line is also later. Scribbling is random in something. So that is scribbling. So that is first. When you do a proper thing, you don't call it scribbling. So scribbling is followed by. So which is more difficult, horizontal or vertical? Horizontal is more difficult. So scribble means anything followed by vertical or standing line, followed by sleeping line, followed by circle, followed by triangle. So this is the way it becomes more and more difficult, right? So you need to check what exactly is that. This child is 2 years, 2 months old. So age-wise, what other similar milestones at this age that you want to look at? So normally, what would a 2-year-old be able to do with the hands? So we also check for turning pages of a book, no? So 2-3 pages at a time versus a single page at a time. Okay. So make your history complete by adding all this. So be specific about what the baby can scribble, what the baby cannot. What about turning pages? Now, of course, the parents have given a chance with cubes, but you can ask whether they can make a tower of cubes. It depends on whether they've been given cubes to play with, right? All those are other abilities with the hand. Then language. So again,
There is a bit of discrepancy between the pincer grasp and the scribble. Scribble is 15 months, and pincer grasp should have come at 8 months.
And also I wanted to add word draws triangle, no, copies triangle. If you ask him to draw triangle, he may not know what it is. So draw it and ask him.
and again about the grasp. So pincer grasp, maybe you can get a history, but remember you cannot get history of other grasps. Means it's difficult. So always remember there is a difference between developmental history and developmental examination. So history is of big things. So how will you ask history of a pincer grasp? What will you ask?
How does he pick up small things? चना पड़ा है तो कैसे उठाएगा और कैसे मुंह में डालेगा?
Correct. So that's a open-ended question. सिंगदाना या चना कैसे उठाता है? Now, if the parent tells you कि ऐसे उठाता है, then you've got a history of a mature pincer grasp. But if you say, अच्छा ऐसा दो उंगली से पकड़ के उठाता है क्या? Parent has only two options, say yes or no. He tosses a coin and decides yes or no. So don't ask such questions. Okay, fine. Bisyllables language. So that's again a incomplete thing. So complete it properly. So what do you want to say? Bisyllable should have come at what age? 8-9 months. Now here, at what age did they come? We don't know. We need to specify that. And after that, if nothing has happened, so for example, bisyllables at the age of 15 months, and now he is 26 months, but nothing after that. So no one word with meaning. So that's the developmental arrest that is happening, right?
Doctor, I'm confused between the word monosyllabus and bisyllabus. Please explain.
Chalo, bolo.
Baba, like bisyllable, ma, pa, monosyllable.
Okay. Then social waves bye-bye and comes when called. So bye-bye is at what age? 9-10 months. So again, we need to know at what age was it achieved. So this is the way you will give more details about development. But broadly, it looks like there is delay or there's no delay.
There is delay, sir. After 9 months, child has not gained milestones.
Okay. So if you look at all domains, you are saying that around 9 months the child has got stuck at around 9 months.
I think the motor system details tells us that there is an arrest because you have got two good milestones discussed. The remaining we are not sure. So we could still consider very likely that there has been normal development in the first few weeks or months. Thereafter, the development problems came up and it looks to be progressive in the form of developmental arrest. So reasonable conclusion out of this is we are looking at a developmental arrest and therefore a progressive brain disease as well. And there we said possibly a progressive liver disease. So now we combine the two and say what kind of things are there. Could it be still autoimmune? I said chronic immune disorders may not have symptomatology of all inflammation. So what is the symptom of a chronic inflammation? I'll give you an example. Tuberculous lymphadenitis is a chronic inflammation. There is no acute pain, tenderness, nothing. But mild swelling, yes. When you press, yeah, hurts a little. So milder form of symptomatology is a chronic inflammation. But one more factor of chronic inflammation, and that is constitutional symptoms. Loss of appetite, loss of weight. That is important. So here we would have been clearer because all that we know is any liver disorder, you rule out infection, then you are almost left behind with either an immune or a metabolic disorder unless you have some congenital malformation as the next thing. Even this tells you that to begin with, this child may not have been bad. Okay. So story starts later. Of course, the problem might be existing already antenatally, but the story starts later. Just one clarity. Today we don't call weaning. We talk about complementary feeds. Okay. Weaning is removing one and putting another. Here, breastfeeding is not removed. So complementary feeds, right?
And what is the word for introduction of milk? 6 months the child is breastfed, and now I have introduced milk. Or 4 months the child was breastfed, and at 4 months I had to introduce milk. What is the word? Supplementary. Okay, so you are supplementing with the same article. So supplementary milk feeds and complementary feeds.
So my impression on history is a 2-year, 2-month-old male child presenting with chronic progressive abdominal distension with intermittent episodes of jaundice, which is suggestive of organomegaly, most likely a hepatomegaly or hepatosplenomegaly, with global developmental delay and seizure disorder with consanguinity, without significant ANC, birth and family history, or without any history of significant organ dysfunction, which is most likely a case of storage.
Would you argue against 2, 3, 4?
So congenital torch infections, there has to be the presentation is late. So he has started manifesting at around 1 year of age. So that is one thing that goes against torch.
Which is not against. Congenital infection damage has occurred early, but the manifestations could be so minimal. For example, a congenital toxoplasmosis may come with hearing impairment even at 6 and 8 years of age. But isolated one kind of a damage more than the rest is easily overlooked. But not this kind of a damage. Jaundice and delayed development, that's too much. And that's why you are right. Okay. What about congenital hypothyroidism?
Hypothyroidism will present with intermittent episodes of jaundice, global developmental delay, and abdominal distension, but not organomegaly. So the organomegaly component goes against, and such a significant organomegaly goes against hypothyroidism.
Again, in the discussion, we have said this child must have been reasonably fine in the first few months. Okay, thereafter the story started. So probably not even congenital hypothyroidism, and hematological is out because we already said that this is a direct allodin. So storage. Okay, why do you call storage? Metabolic disorders may not be storage. Two types of metabolic disorders clearly, one without storage and one with storage. Why is he calling it storage? Metabolic, yes, that we all said.
Because of organomegaly presenting with global developmental delay favors more of a storage form of pathology where there is
Very
where
good.
the
What he
metabolic
means
products
is
are.
invulnerable metabolism which do not have storage are an acute onset metabolic disorders. Vomiting, seizure, failure to thrive. Okay. One which has storage are slowly progressive. And this is slowly progressive. So this is a slowly progressive storage disorder. Okay. And therefore Wilson is slowly progressive disorder. But look at tyrosine comes much faster, but may have a wide variation. But if you look at many others, a normal newborn delivered normally goes home on breastfeeding and in the first week comes with a sudden vomiting seizure. And he's admitted, you put him on IV, nil by mouth, and in the next 1 or 2 days he is all right. Because you took away a source of damage and you discharge him many times, saying, we will do investigation, reports will come later, but he's all right, go home. And then he starts feeding again and he comes again. Acute onset, this is a slowly progressive. And what kind of storage disorder? Protein, carbohydrate, fat, or any minerals, copper. We said storage may be even copper and might come early. What's your guesswork? Come on, somebody. No? Guesswork, no? You have a mic, yeah.
Glycogen storage.
Glycogen storage, you are saying, because it's more common. Okay. Any other thoughts?
Are people doing MD pediatrics more common? No, so that's not an answer. Yeah.
Come on, any thoughts? Any other thoughts?
It's predominant hepatomegaly with history of seizures. So most likely a hepatomegaly with seizure, liver being the storage organ for glycogen, and a child presenting with seizure, and we don't know the sugars at that time. So can be a hypoglycemic upset.
Okay. Go on.
Just diverting a little, congenital hypothyroidism. Can we have a child with congenital hypothyroidism whose earlier milestones are normal? Because we always say, oh, hypothyroidism is just be lethargic, constipation, jaundice, etc. 10, 15 things are there. Can you have a relatively normal milestones in the earlier part and presenting only later 6 months, 8 months, 9 months? Can you have that? Or congenital hypothyroidism? Yes, because there are some enzyme defects wherein the child produces enough thyroxine to have initial manifestations, and later on there is a deficiency of that one, and therefore the later milestones may be affected, and this may not be very rare perhaps. So if earlier milestones are not affected but later milestones, we don't in our mind rule out congenital hypothyroidism.
In fact, such hypothyroid, which is of a low degree hypothyroidism, can come with just one of the symptoms presentation, like a short stature, but how is he doing in school? Not bad. Okay, or maybe just a poor school performance, and he's not so bad in height. So that's what he's saying. Even school level, you could pick up. It's not severe enough, so you don't have much of lethargy. But when you go into detail, how is the bowel movement? No, he passes, but it's often hard. Sometimes he misses. That means there are subtle issues, and that's what he brought out.
So moving on to the examination of the child is alert, appears comfortable in mother's lap. The child was afebrile with heart rate of 128 per minute, with regular beats, with respiratory rate of 34 per minute, which is regular. Saturation was 99% on room air. Peripheral pulses and central pulses were well filled. Blood pressure was between 58 to 98 centile, and capillary refill time was less than 3 seconds. The blood sugar was 90 milligrams on presentation. On head-to-toe examination, there is pallor, there is icterus, which is noted in the eyes. There are no dysmorphic facies. The eyes and ears appear normal. There are no rashes, petechiae, or purpura. The abdomen is distended with visible veins, and the umbilicus is central and inverted. The limbs, spine, and genitalia are normal. The child has normal male genitalia with bilateral palpable testes. So anthropometry wise, the baby's weight is 9.75 kilos, which is between -3 to -2 standard deviation. The height is 80.5 centimeters, which is between -3 to -2 standard deviation. The head circumference is 46 centimeters, which is between -2 to -1 standard deviation. The mid upper arm circumference is between -1 standard deviation to median, and weight for length is around -1 standard deviation. So the child is
Comment on head circumference.
normal, sir.
I wanted it to be between -3 and below 3. But it is better than his other height -3 to -2, weight -3 to, and this is even better. Minus normal to birth weight -1. That means the head has grown much better than the other parts of the body. And we are
Maybe the disease is not severe enough to compromise CNS.
In other words, the problem started manifesting somewhere 3-6 months later in life. Okay.
The child is underweight and stunted for his age. On systemic examination, the child has distended abdomen on inspection with predominantly the upper part than the lower part. There are visible veins which are non-dilated or tortuous. The umbilicus is central and inverted. The flanks appear full, and there are no scars, sinuses, rashes, or ulcers visible. On palpation, there is no tenderness or rigidity. The liver is palpable with size 10 centimeters below the right subcostal margin in the mid-clavicular line, and the span is 16 centimeters. The liver is firm, smooth, and has regular surface with sharp borders, and the left lobe is palpable 5 centimeters below the xiphy sternum, and the spleen is not palpable. On percussion, there is dull note over the abdomen. The liver is so massive that it is actually occupying almost the entirety of the child's abdomen. On auscultation, the vowel sounds are heard normally. On CNS examination, the child has hypotonia. The child has alert with power more than 3 by 5 in all four limbs, with reflexes 2 plus. The bilateral plantas are flexors, and there are no obvious cranial deficits, no involuntary movements, or no meningeal signs. The cardiac examination and the respiratory examination are normal. So my provisional diagnosis for this child is a 2-year, 2-month-old male child presenting with complaints of chronic progressive abdominal distension with intermittent episodes of jaundice, with global developmental delay and seizure disorder, with consanguinity, without significant ANC birth and family history, without any history of significant organ dysfunction, with examination suggestive of gross isolated hepatomegaly, without eyes, ears, or skin manifestations, without any dysmorphic facies, in a well or a non-sick child is a most likely a case of storage disorder and most probably a case of glycogen storage disorder. So I actually have the photos of investigations and the photos of this child. So the investigations revealed with HB of 9.5%, 28% hematocrit, 11,300 counts, and 5,75,000 platelets. It was normocytic, normochromic with hypersegmented neutrophils seen on PS. Total bili was 4.2, direct bili was 2.3. OT-PT were slightly high, with OT being 133, PT being 311. ALP is 323, GGT is 180.4, total protein is 6.3, albumin is 3.8, RFT is 14 and 0.5, random blood sugar is 112 mg per deciliter. Triple H was non-reactive, and USG A plus B has suggestive of altered ecotexture of liver, and fundus was normal. So we had taken Pete's gastro reference, and we had sent genetic studies for this child. The genetic studies revealed homozygous variant of the gene PHKG2, which is consistent with the phenotype of the child, and that is suggestive of glycogen storage disorder type 9C, which is of autosomal recessive inheritance. So this is the photo of the child's abdomen. And just in short of the GSD type 9C, because it is a very rare case, is a deficiency of enzyme phosphorylase kinase, is a rate limiting step in glycogenolysis. This enzyme has 4 subunits, alpha, beta, gamma, and delta, and it is each encoded by different genes. There is involvement of muscle and liver phosphorylase kinase, or both, depending on the genetic involvement. So this is the pathology is involved where the glycogen phosphorylase B inactive gets converted into glycogen phosphorylase A active form, which then helps in breakdown of the glycogen to glucose 1-phosphate. There are pathogenic variants causing liver phosphorylase kinase deficiency, and the children can have variable clinical manifestations from mild to recurrent hypoglycemia, prominent hepatomegaly progressing to cirrhosis, along with cholestasis. There is delayed motor and cognitive milestones along with hypotonia. The diagnosis is confirmed on genetic sequencing. Most of the patients have elevated transaminases with normal uric acid and lactate levels. The treatment for liver phosphorylase kinase is usually symptomatic and is complex carbs with cornstarch. So this child has been on follow-up with our pediatric gastroenterology OPD, and he has been started on cornstarch and is on follow-up.
Any scope for liver transplant?
They are planning, but depends on the affordable.
But metabolic disease, no, so it will affect even the transplanted liver.
If the child develops liver cirrhosis, there is an indication for liver transplant.
No, what I mean is, if you are transplanted liver, that liver is also going to get affected with the other liver, no?
Enzyme replacement therapy.
No, the liver, what? Answer is the liver which is transplanted is
Does not have the
metabolically normal.
normal.
So it is not going to, in fact, it will compensate for the abnormal liver. If you had seen him earlier with a big distension of abdomen and ascites, would you have entertained the diagnosis of Budd-Chiari? Such a huge distension of abdomen, ascites, hepatomegaly.
Budd-Chiari usually doesn't present with jaundice. Okay, there is a marked hepatic venous congestion. So it's a congested liver, and like a CCF rarely presents with jaundice. So there are reports that even a CCF may have a mild jaundice. It is similar to. So probably jaundice is not a feature, but ascites is a major feature because of hepatic. I just wanted to comment on two things. One, if you talk about recurrent jaundice, not just in this case obviously metabolic glycogen, it was clear, but recurrent jaundice could be also hepatitis B or C. So keep that in mind. Autoimmune inflammatory disorders of the liver are often with recurrent jaundice. Then even the hereditary disorders like PFIC. PFIC is of 3 different types, and they have a different progression. Somebody is very mild and goes slowly. Somebody may recur, and the third one will just go bad and finish. So such disorders we need to keep in mind for a recurrent. So autoimmune is one, infection also. And then the third, of course, is metabolic. So recurrent jaundice is a feature of all these 3 groups.
Sir, I was just wondering, all inflammatory disorders, autoimmune, some fever has to be there at that time, inflammatory, especially when the jaundice has appeared because of inflammation, which is severe enough. Or at that time, those few days or weeks, the child should have downward health. Is that valid?
I think acute inflammation, yes. But when it's a chronic ongoing inflammation, and the typicality of immune disorder is up and down, and therefore their health may not be tremendously affected. Unlike a metabolic disorder, where jaundice may be recurrent, but the process is continuous. So immune disorder is likely even without tender, but acute inflammation, yes. But most of these are chronic inflammation, and therefore very likely they look alike, normal, but of course with a lot of abnormalities. So failure to thrive may not be a very strong point, and they are not usually the multi-system affection. Here there is a multi-system affection, and possibly feeding is a problem, but many other factors might have come. But I must congratulate him for one reason. Okay, he presented very well, but he gave a short one slide summary of what this disease is. And I think it's a learning point for all of us. We must end up with a small thing, very important. Even if you pick up few lines and register it here, it will be a great thing. I think that was very amazingly excellent. Thank you.
And no long history of no history of this, no history of that, no history of that, because that reduces your, I mean, it improves your understanding.
Already saying every time that short of saying no history of similar disease in the neighbor, okay, everything is no history. He had some 5, 6 only. Good job done.
Our online viewers, do you want to make any point? Dr. Palni Raman, Dr. Anjali, anybody?
Excellent discussion, very good case, and very well presented by the youngster.
Okay, thank you. Thank you. Anybody else wants to make any point? Okay, so we move on to the second case for today. Can you see the slides?
Yes,
Okay.
but it's not full screen.
Yeah.
Good evening, everyone. 4-year, 5-month-old girl child, first by birth order, born out of non-consanguineous marriage, hailing from UP, resident of Vikhroli, Hindu by religion, Prajapati by community, brought by mother with the chief complaints of fever since 8 days, intermittent vomiting since 8 days, abdominal pain since 8 days, and not passed urine since 12 hours. Child was apparently all at 8 days back when she developed fever, high grade, undocumented with medications, but reoccurs, active in interfebrile period, associated with chills, not associated with any rash. Abdominal pain, intermittent dull aching, periumbilical in region, non-radiating, not associated with any aggravating or relieving factors, not associated with any night awakenings. Vomiting 6 to 7 episodes per day, non-bilious, non-projectile contained food particles, not blood stained. It was for 1 day and then not any recent episodes since now, associated with nausea. There's history of decreased urine output, history of lethargy present, and history of reduced oral intake. For above complaints, she took following medications: amoxicillin, cefixime, ivogesic, mefenamic acid, and symptomatic treatment. There is no other history of crying while micturition, cough and cold, loose stools, no history of bleeding from any site, no history of altered sensorium. There's no history of any past admissions. ANC is uneventful, registered 2 USG scans done, told to be normal. 2 TT injections taken, iron, folic acid, and calcium supplements taken. Adequate weight gain present, and no history of any GDM, PIH, hypothyroidism, or any other complications present. Birth history, full term normal vaginal delivery, carried immediately after birth, birth weight of 2 kgs, no history of an ICU stay, no history of neonatal jaundice, and she received birth vaccines. Immunized till date. Developmentally, she's appropriate for age. Gross motor walks stairs downstairs 1 feet per step. Fine motor copies circle and square. Language says poem. Social enjoys group play. Dietary sheets from family pot, consumes mixed diet. Calorie deficit of 250 kilocalories per day and protein deficit of 4 grams per day. Family history is non-significant. She's a single child, belongs to upper lower socioeconomic class. On examine,
So now let's start talking. What do you make out of this history? So what do you think of the fever? What do you think of the fever itself? So when I say what do you think of it, means you think it's an infection. Mostly any short duration fever is an infection. So whether it is non-infective, any small doubt, or it's infection. Then if it's infection, viral or bacterial, this is the usual approach that we have. So what do you think?
it's an infection. But mostly bacterial because it is for 1 week.
So what you are saying is that normally viral infection should have settled in 4 or 5 days. If it is going on for 1 week, that is one point to consider whether it's bacterial. Of course, viral or bacterial depends on many things. You have to consider a lot of things. So what are the other things that you have to consider? Any other points? Ask for the mic and speak in the phone.
Active in interfebrile period. So,
Okay, so active in interfebrile period, if it is correct, then it goes up, favors a non-bacterial infection. Then lethargy is there or not there? Yeah. Okay, lower down, history of lethargy. So before we come to that, it's written associated with chills. So what does that say? Mike, speak in the mic.
Indicates a high grade fever, sir. Chills.
Okay, it indicates high grade fever. What else? Means what is the localizing value of chills? Does it indicate malaria?
Bacteremia or toxemia.
Okay, so you cannot get chills in viral infections.
We can.
Can get which viral infections?
In dengue.
In dengue you can get. Then which other viral infection? The classic description of fever of that viral infection is fever with chills, abrupt onset of fever with chills. These are the words written in textbook. Which viral infection? Influenza. Influenza is abrupt onset of fever with chills. So chills is not specific to bacterial. It's viral, bacterial, anything. So you said it's high fever. Then, so the point I was trying to make is that we need to have all this as a story. So we need to know when did the abdominal pain come in, When did the vomiting come in? When did the lethargy come in? Because that whole thing has to go like a story, because there could be differences in interpretation. So abdominal pain is since the beginning, since day one. Okay. So intermittent dull aching, periumbilical, no aggravating, nothing. So what is the anatomy of this abdominal pain? Then Nantar, I'll be able to ask, because apparently it's only for one day. We'll come to that. What is the anatomy of the abdominal pain? Yeah, so which organs are there periumbilical? Small intestine, very good. What else? Okay, gastric, so stomach. Then which other organs are there periumbilical?
Dysentery also.
Mesentery, lymph nodes. So mesentery means peritoneum. Okay. So where do you think this abdominal pain is coming from?
Gastroenteritis, enteritis.
So where is the enteritis? Where are the loose motions? Where is, huh?
Since there is vomiting and periumbilical pain, gastritis can be there, and child has received mefenamic acid also. So
that is why I was saying, na, child has received mefenamic acid and so many other acids. So whether the vomiting started after that, that sequence is very important to know whether it is. And when it comes to gastritis, can gastritis go on for 7 days? I mean, you're talking of abdominal pain as gastritis. So can it just go on for 7 days? Or is this a gastroenteritis which got arrested at the gastritis level? We just had a mental arrest case. So what do you think? Vomiting is which day of the illness?
First day of the illness, vomiting was present, then it was intermittent. One day it was there, one day it was not there. But 6 to 7 episodes occur on the first day of the illness.
After that, over the next 7 days, there has been some vomiting, not persistent. Okay. Overall, is the severity of the abdominal pain a lot or it's just there?
It was a lot. Parents complaining of abdominal pain only, like हमेशा abdominal pain ही रहता है.
That was their chief complaint. Okay. And fever was not documented, but it was high fever.
I think we have discussed about fever, all right. We also said that dull ache is usually an organ involvement, and we said small intestine or maybe a lymph node. And therefore, the question is small intestine may not necessarily have diarrhea. That's it, number one. And therefore, it's a typical small intestine which presents with a watery diarrhea, large amount, frequent. But if it's a little lower down in the large intestine, then the diarrhea will not be a major issue. Sometimes even a constipation and diarrhea intervening, and therefore a slow progressive inflammation doesn't cause like a dysentery, acute onset, loose stool, blood, mucus, etc. Therefore, small intestine stays. Okay, could it be a lymph node? No, because a lymph node to cause pain takes time unless the lymph node enlarges to a reasonable size. And why is the pain in lymph node? It's not just lymphadenitis. It's a slowly inflammatory enlargement of the lymph node where the capsule is stretched and you get some mild pain. So the pain is dull, pain is not a major feature. So this is not lymph node. You said pain is a major feature. So this has to be an intestine. And this has to be probably a large intestine. Therefore, stools are not a major issue. And to that extent, what Dr. Rajesh has been saying is we need many more details sequence, severity, progression. And unless we know, we may not able to comment it so much. But vomiting also continues, but it was severe only one day, and thereafter a small vomiting once in a while. So vomiting may not be given a lot of importance in our discussion, and therefore vomiting, I would say, is self-limiting to a large extent, though occasional vomiting continued, and that could have been drugs also doing it. So we will only discuss persistent high fever for a week and probably persistent severe abdominal pain, dull ache, periumbilical. Could it be appendix? Starts with periumbilical and gets to the right iliac fossa. Chronic appendicitis. Appendix goes like that, no? Periumbilical and then right iliac fossa. What's your comment on that? It's a part of intestine. It's a part of almost lower intestine, large intestine.
So what is odd or what is not fitting in acute appendicitis?
Not associated with night awakenings. Not really.
High fever is not a issue, and the periumbilical pain shifting to right iliac fossa is an acute appendicitis. Happens in 24 hours. So I was just trying to ask you whether this would be that, and therefore it is whatever little that we have now. We don't have many details. It looks like an inflammatory disorder, persistent inflammation, probably large intestine, and we leave it at that. We won't know whether it's an acute or chronic, etc. But that is all that you
Can it be typhoid? Come on, give your thoughts. So points for and against.
More right hypochondrial pain will be against periumbilical pain, more towards right hypochondrial pain will be there.
You mean in typhoid there will be right hypochondriac pain? What else? So the fever should have been a rising trend of fever. Of course, again, the patient has received some antibiotics, so it is like partially treated or confusing. So that might affect the clinical picture of the fever. Usually, typhoid does not have severe abdominal pain. So if the pain is genuinely severe and she's saying it's the main complaint, then that's a little again typhoid. And can it be liver abscess? Fever and severe abdominal pain.
This child won't be active in interfebrile period.
It will be more localized to the right hypochondriac.
Yeah. Typhoid doesn't start with high fever. First 1 or 2 days, mild to moderate, and from third day onward it goes. So we don't know the details. What I was thinking was even abdominal pain, whether it is intestinal, peritoneum, coming simultaneously with day one of fever is uncommon, because whatever complication has to take place must take place on involvement of intestine, peritoneum should come after day 2, day 3. So initially started with fever and later on localization or affection of bowels or whatever. My also thinking was a hollow organ like intestine, large or small, when it has the pain, it may have a constant pain but must have a colicky pain, because intestinal pain is colicky. If there is an inflammation, there may be constant pain, but the history should be कभी कभी बहुत रोता है, आधा घंटा बहुत दुखता है, बाद में नहीं होता है. If there is a dull constant pain, it is inflammatory, probably primarily involving peritoneal tissue rather than primarily involving intestine. But in either case, the pain should not have started right in the beginning. onset of vomiting little later always worries
is a
me.
complication. So that's why the details we want.
So,
Vomiting
sequence
at
is
the
important.
beginning has localizing value. Vomiting after a certain time has a value as a complication.
And including everything, including CNS. So I think the fever must have started first. Vomiting and abdominal pain must have come up later. It was acute exacerbations, colic in nature, pakad ke baitha, then for 1 hour, 2 hours, 3 hours is better than again. Then it is small or large intestine. A constant pain, moderate with little aggravation, may point towards peritoneum. Lymph nodes are unlikely. So, sort of say peritonism and fever, most probably inflammatory in nature. If it has occurred over a period of time and slowly rising trend, then maybe enteric fever may be an important thing. In large intestinal, the only large intestinal infection we know is bacillary dysentery or the inflammatory bowel disease. In inflammatory bowel disease also the onset seems to be rather acute, and we'll diagnose inflammatory bowel disease only when it is recurrent and not at the time of first minute. So I was thinking whether it is primarily peritoneal tissue with inflammation infection. That was the thinking.
So now we don't know whether these parts of history are missing or incorrect or they are not there. So we cannot exactly interpret, but we are just learning why all these small details are so important. It helps us to get a better analysis.
And also to take out another possibility, even if it doesn't appear logical, because this is to just have a different line of thinking. It may not be possible here, but unless you think from different angles, your mind doesn't remain open and we get biased only on one side.
I think to me, acute peritonitis is out of question. One is that he's a very sick child, and this is the primary peritonitis, which is again another unusual thing. I can understand a nephrotic syndrome coming with acute peritonitis, but not otherwise. Peritonitis is a complication of some intestinal disorder, and therefore that is unlikely. Again, when it comes to colicky pain, it's only largely a small intestinal colicky pain, and that too acute inflammation. Now, here we said fever, vomiting, and pain started almost by one day. I mean, maybe fever first, 12 hours later, but still all together. Now, all together tells me that this is unlikely an infection, but it could be an inflammatory disorder, which could have any kind of a combination. So that is number one. Second is vomiting is of no significance to my mind here, only because it was only first day several and thereafter got better. Had it been of an importance, we said that vomiting coming later in the course is a very important point of localizing somewhere. But here vomiting started off and then within a day it eased off. Therefore, to me, vomiting may not be a great point to discuss to come to a conclusion. So you are left with fever and an abdominal pain. And I think whatever little we have understood, you have taken the history all right, but we are learning how history is not his story. He keeps on saying that. History is the thought in action. Every symptom that mother talks about, I start thinking and I said, what else could it be? Let me ask the mother some relevant questions. That is what we discussed. So at this point of time, the best bet is it's non-infective inflammation. The best bet is involving the intestine, likely small intestine, large intestine. If it's small intestine, it's higher up, like a duodenum, for example. A typical Crohn's don't come with diarrhea necessarily. At one stage, there is a lesion in the duodenum. At the other end, there is also another lesion in the large intestine. So the diarrhea may not be a feature necessarily of a Crohn's. So something of that kind, right?
So now again, just for understanding, we are discussing, see, all these antibiotics were taken for one day. Now, one day when? Now, yesterday, say one day, or somewhere in between, or one was taken, then one was changed, because it makes a difference in your thinking. If it was just yesterday, That means first 5-6 days, no antibiotic. Then you look at which disease can, what is the history of the disease without an antibiotic. You understand? So these things are important.
Mother changed the antibiotics every day. Every day they went to a different practitioner and
That makes the clinical picture also a little confusing. So the original classic pictures will not be there.
And the point is with even haphazard treatment, the story hasn't changed much. Fever continues, abdominal pain continues. So what does it mean? The drugs are not working. But had it been an infection, it would have got worse. So possibly that again, to my mind, is a non-infective inflammation. I think we are depending too much on history, but it's a good idea. If this was the history, then this was the conclusion, kind of.
on examination, child was afebrile, pulse rate of 134 per minute, regular in rhythm.
Afebrile and pulse rate 134. Please conclude.
So you could have said, I checked after paracetamol was given, pulse rate still high because he is sick.
What I mean is, we get such high pulse rate in a big child like that, mostly with fever or other systemic causes where he's getting tachycardia. Normal temperature and 134 is reasonably high. So
Anything
I'm
else that
concerned.
bothers you on that slide? Huh? EP is 5th centile. So it bothers you.
Extremities are war. So maybe a shock.
So if extremities are warm, is it shock? What about bounding pulses? For a 134 heart rate, bounding pulses. So again, if they are really bounding, then that combo of 134 and bounding is very important. Understood? That combo points to sepsis. Right? Then you say warm, so warm phase of sepsis. Right? So that's very important.
Peripheral pulses bounding, central pulses well felt, respiratory rate of 26 per minute, regular, SpO2 of 99% on room air, extremity is warm, BP is near 5th centile. Head to toe examination is normal. Anthropometrically, child is normal. System examination per abdo soft, uniformly distended, non-tender, liver of 2 centimeter below subcostal margin. The systemic examination is within normal limits. 4-year, 5-month-old male child, fully immunized, developmentally and anthropometrically normal. It's probably case of acute febrile illness or drug-induced ALF or an AKI. As investigation,
Acute liver failure or acute kidney injury. Come here. Wait, don't give us the message. Come here. So why are we discussing these two? Amdekar is asking. And you're not criticizing, you were asking you justification. No, so is there anything in the history? So does that abdominal pain tell you it is a liver failure, or does that vomiting tell you it's a liver failure, or does that both of them tell you it's a kidney injury? What made us think of these two?
just decrease urine output.
Okay, so decrease urine output, again we need details, no? So decrease urine output since when? So how decreased? And even on history, and then since when? All that is important. And when you said lethargy, so lethargy, again you have to qualify that. So what exactly do you mean by lethargy? What happened? Was it since yesterday? What?
Lethargy was since 1 day back. Like when there was she presented with
So what
not
did the
passing urine.
parents say? Lethargy means you asked them or they said something?
I asked them.
कि क्या? What did you ask?
कि बच्चा पहले से सुस्त रहता है क्या, मतलब जितना वो उठता है सोता रहता है. They said कि हाँ, she's not waking up as usual.
So now I'm asking you, somebody who's unwell for 7 days, वो पहले से सुस्त होगा कि नहीं होगा? Common sense. So you have to quantify, no, whether it's just the 7th day of the illness or that lethargy bothers you. Again, you'll have to filter it out from the history. Okay.
I think till you showed this slide, we said that there is some sepsis occurring. Okay. And then this is an acute sepsis in a short period. So likely it will have some other organ dysfunctions. Now, what other organ dysfunction you probably had was some lethargy. But that's a loose term. We are not sure what it means by that. Any sick, very sick child looks lethargic. So possibly your ALF and ARI, etc., are based on your investigation. Clinically, no. And why investigation? We already said when you are in a sepsis, you need to look at every organ that could be affected and could be affected biochemically much before even clinically. But it's not fair to say there is an LF or a kidney injury. Clinically, there is no kidney injury, but biochemically that can come up in a sepsis, and that is a part of sepsis. Question is why sepsis? All that we know is that there is some intra-abdominal problem. Intra-abdominal problem without any localization. Could it be a pyelonephritis? Okay, 4-year-old. Why should he suddenly get a pyelonephritis? So it could be that he had some malformation somewhere and it got infected. But you had a fever where in between fever the child looked all right. So unlikely again. So I suppose this is where we get stuck up and we say we don't know what it is. This only teaches us how important is the detailed history taken. Okay. Otherwise, investigation will die. Then in the next Thursday, we might start with investigation first, and I'll ask you what must be the symptoms and signs, because that's the final diagnosis. What we are learning is how to take a detailed history and analyze it. Doesn't matter. We are all learning. Okay. Point to make is that we talk after years of experience, and you are talking with very little experience, but both of us are showing our ignorance more than wisdom. So we both are on the equal level. The difference is how long it took me to be ignorant and how still you have a hope to be not ignorant. That's the only thing, right? So that ALF and ARI, remove it. Just show us the path.
On presentation, showed a hemoglobin of 10.6, hematocrit of 32.1, counts of 11.35 thousand, and platelet of 89,000. The platelet count improved gradually. And RFT on presentation was 39 1 and creat of 1.3, which worsened over the today's creat was 2.8, 1 of 48. LFTs on presentation, T value of 2.7, D value of 1.4, OT is 9990, SGPT is 9380, ALP of 291, total protein 5.8, albumin 3.9. Today's is 1.8 of T value, D value of 1, OT 365, PT 2535, ALP of 201, total protein of 5, albumin 3.4. SC is 137 and 4. A PT INR of 19.2 and 1.6 INR. We need happy, which is negative. Urine for bile salts and bile pigments were negative. USG A plus P was done, which is not abnormally detected. CRP of 2.4, ESR of 39, Vidal negative, and urine RM is NAD.
Go back. The bilirubin. I'm just pointing out that if you have a direct bilirubin of 1.4, you cannot have urine with bile salts, bile pigments negative. You have, right? Here. So there is some mismatch. One of the two is not right.
How do you look at very mild increase in bilirubin, but a very high all SGOT, SGPT, tremendously increased? Okay. Thousands. How do you correlate the two? Oh, high. What does it show you? First step, you should be sitting here with us now. Yes. It means an acute liver injury. Okay. So I think also has gone up. So the question is, initially we said sepsis, we did not have any of these. Clinically not. But an acute onset multi-organ affection due to sepsis. The question is, what's the cause of sepsis? So my question is, does sepsis mean only bacterial infection? Or sepsis is an immune process to some trigger? What do you think?
Yeah, so can you have sepsis in a viral infection?
Can you have sepsis in malignancy? Can you have sepsis in inflammatory disorder? Question is, generally we talk about sepsis due to bacterial infection, but it's not just that. It could be any trigger that has a sensitive immune system to react that way. And I think that there was no other organ involvement at that time except intra-abdominal problem. And we were not able to localize the bacterial infection there to call it sepsis. So I start wondering whether this is a non-bacterial infection triggered as a sepsis, and we will have to really look at it what it is. We'll have to resuscitate this slide and then follow it up to see where we are as far as the abdominal problem is concerned. Do you have any follow-up for a short time?
Sir, another point. Within 2 days, the SGOT has fallen from 10,000 to 365 in 2 days.
So which means that the multiple organ abnormalities are now general abnormalities.
So the child, when we had started the child on NSC, we had started the child on NSC infusion. After that, the report is this, and child deteriorated and was shifted to PICU and intubated for bad sensorium, and she had pulmonary hemorrhage there.
No, so I'm not getting your point. You had started the child on NaCl infusion, and after that you're saying the OT.
N-acetylcysteine.
N-acetylcysteine.
I think falling down of SGOT means that the muscle injury is less, but the liver injury continues. And therefore, the general muscle, after all, SGOT comes from intestine, it can come from the WBCs, and of course, it can come from muscles of all kinds. So that kind of damage seems to be under control, but the liver damage is between OT and B.
This also tells me that renal function is deteriorating and there is involvement. So we think of hepatorenal. This child has hepatorenal syndrome due to whatever cause.
Sir, but in hepatorenal, it is hepato leading to renal, whereas here both are with some other primary.
But progress is with renal, while progress has
The
not
bilirubin
been.
has not gone up.
And,
So
and
the liver has
hepatic
not
is
deteriorated.
But only the kidney function is deteriorating.
No, that's fine. SGOT only means the cellular enzyme has come out. If the liver has not deteriorated, okay, the enzymes are because the liver cells are damaged, so the enzymes have come out. It will take time for them to recover maybe, or it may progress. But the progressive hepatocyte disease was kind of development going on. Not only just the enzymes. So I don't think this is progressive liver disease, damage is still there.
And what is happening to the urine output over these 3-4 days?
The urine output was around 1.8 to 2 cc per kg per hour.
Which was fine.
Yeah, it's fine.
So again, clinically the urine output was never bad. It was only biochemically that the creat was going.
Child was not
put up
passing.
ALF and ARR because biochemical, yes. She's ahead of us.
Now you said clinically what happened after this. So you started N-acetylcysteine for what? What did you have in mind?
Drug-induced sepsis or toxicity of liver. Suspecting that, we started NAC infusion, and vitamin K was given for rearranged PTINR. Then sensorium got bad, and child was shifted to PICU and intubated there.
This child has taken a lot of loose medications from outside. Some of them she has listed along with the dosages. So this child had presented even though on presentation she was alert, later she became drowsy, and then she has the sensorium has deteriorated. There was acute drop in GCS, that's why the child was intubated. There have been breathing manifestations and emergencies since the child was admitted to PS. Initially she was non-olivuric, but since last 12 to 24 hours she has been olivuric. So there is definitely a component of renal failure or liver failure component because she has received so many medications. We were suspecting induced injury in this. So we had started on N-acetylcysteine infusion for this child, and the second report is after the starting of the N-acetylcysteine infusion. So maybe that might have caused a difference in the values. But overall, the child has been on a deteriorating course, and we are still trying to figure out the etiology for the child. Whether it is a drug-induced cause, whether like what exactly tipped off so much that the child deteriorated within a span of 3 to 4 days, and with no significant other history or no significant past history.
What happened to the fever?
The fever is still persistent, sir. She's still having fever spikes. Actually, she is having persistent fever spikes since admission, and there are now other bleeding manifestations. The child has pulmonary bleed. The child has altered RT aspirates and she was brought to the PS. So there are bleeding manifestations for which supportive management is ongoing.
How will you know whether the shock is getting better or not? So when we all started discussion that it's in shock.
The shock component. Clinically, it depends on three things. One, the sensorium. Once the shock starts improving, the sensorium will improve, the vitals will stabilize, the urine output will start improving once the organ perfusion will be established. The child will start to accept feeds for whatever that is being given through it. So there will be clinical parameters for improvement in shock, and then there will be biochemical parameters for improvement in shock in form of improvement in blood gas, improvement in RFP. So that the resuscitation and the supportive care is still ongoing for the child with PSC.
Blood pressure are the most important. And of course, the renal perfusion.
So clinically heart rate, and of course for tissue perfusion, what would be your measure? The urine output is dicey because after a acute kidney injury, you could have a polyuric phase also. So urine output is dicey.
The peripheries.
One is clinical peripheral perfusion as judged by CRT peripheral pulses and the lactate. So lactate is your sign of tissue perfusion or investigation.
One parameter of organ perfusion is the mean arterial pressure. And I think the historical diastole we could calculate the mean arterial pressure. And if that is all right, then organ perfusion is fairly good. Because that's another way actually to measure that. So, because,
could this be Reese syndrome?
Rise syndrome.
Rise syndrome is usually an acute onset hepatic encephalopathy. First thing is acute. Second thing is that there is no time for jaundice. There is a hypoglycemia, hyperammonemia, and a hepatocellular
And hepatomegaly.
Yes, hepatomegaly, but functionally, it's an acute onset, hypoglycemic, hyperammonemic, liver failure. There is no time for developing jaundice symptoms. Possibly not a rise, but what he's talking about is not directly infection, but some other factors causing all this. And I think that's what we are considering, that we are not factors could be behaving like this is what we are not clear.
There's no capillary leak.
The rash should have affected the sensorium much earlier. It's given 7-8 days. There's enough explanation of outer sensorium on the basis of circulation. Rash syndrome presents with hepatomegaly, hyperglycemia, and outer sensorium relatively early, though one has not seen too many cases now.
I was just wondering, sir, that drug-induced injury, once you stop the offending drug and you are supporting the organs, it shouldn't have a progressive course. So therefore, it looks like the original illness is only progress.
And see, if you say drug injury, then it has to be renal or liver, but not both. The mechanisms are different. So to put both together, it must be a disease doing it. Maybe some small contribution by the drugs, but the drugs are given for a short time comparatively and not loaded with lot of harmful drugs. I imagine so. So drug may be additional factor, but we could ignore it, and now the drugs have been stopped for quite some time, and still the problem is not solved. So unlikely a drug interest. It was a good case to, and well known presented, and we could guess that her final diagnosis was also based on her biochemical findings normal, and that's fine. But I think this was both the cases today were very good and very informative. And the best part of knowing how little you know is at the end of both the cases, we are unsure of them.
Usually, Dr. Palni, you want to make any point?
No, sir. No, sir.
Rajesh, initially, Dr. Ripa had also said that it could be H. pylori when there was vomiting, but fever was against. And Dr. Palni Raman had said that so many systemic complaints, it could be viral infection. I would like to add that the history seemed little incomplete. I think she should have included the whole progress of the illness. How
Correct.
this child.
So that we told her. Obviously,
Yeah.
she's a junior resident relatively. So
Yes.
I thought we told her that the history has to be more accurate and more deep. So that
Yes.
point is okay. Yeah. So it did look like as Amdekar sir pointed out, it was not localizing to any one particular
Yes.
bacterial infection. So either
Yes.
it was not bacterial infection or no infection, that we were not sure.
Anjali, even considering viral, it looks
Yes.
very unlike that the only symptom is even abdominal pain.
Yes,
And
sir.
that's an unusual symptom of a viral infection and going on for 8 days with same frequency or same severity of fever. This looks
Unlikely.
very viral.
Yes, sir. And you rightly said that her diagnosis was based on investigations. So I have just one more thing to add. Could this be any congenital or a genetic metabolic disorder? Because we had a similar case who deteriorated very rapidly and was a very remote and a very unlikely diagnosis of a genetic disorder.
Anjali, fever is an unusual feature of a metabolic disorder.
Sir, I think what she's meaning is that whatever was the illness, infective illness, has triggered of
Yes, a genetic metabolic genetic.
Whatever the trigger is still persisting. It's not something that came and triggered something. When you have a viral infection triggering, the infection disappears and the rest of it comes. Here the story is almost of the same disease going on and on. And I think again the sepsis finally. Okay, if there is a metabolic disorder or genetic disorder, sepsis is not unusual. Again, sepsis is a rare manifestation of those genetic or metabolic disorders. And I know Krabbe's disease, for example, may come with what looks like sepsis, or a tyrosinemia may come like what looks like sepsis. But this is not what looks like sepsis. This was sepsis with multi-organ involvement.
Yes, sir.
Okay.
Was blood culture done?
Sorry,
Was blood culture done?
blood cultures awaited.
And also in an acute hepatic, will also ask for IgM and not only IgG. I wanted to just request that when there is a history of fever, say 6 days, 5 days, you must ask the patients, पहले दिन क्या हुआ, दूसरे दिन क्या हुआ, तीसरे दिन क्या हुआ. They must go. If there 1 month fever, you may not be able to ask that, and that will give the exact course of illness, how the child started high and remained high. It started high from day one and has remained high. The thinking is different. Started low, going high. Started high, so intermittent. This is relatively important for coming to a clinical conclusion. So you can ask because the parents will give what they thought of. पहले दिन क्या हुआ? If they don't know the history, how many times did you have to give paracetamol on day one, day two? That will also tell you what has been the
Also,
progress.
see, you should try to make a graph in your mind of the patient's sickness. So now over 7 days, is the graph steadily worsening like a diagonal graph, or first 5 days the child seemed okay in spite of all this, and suddenly 6th day the child was bad. Some such things, some patterns you have to pick up in the history. Drug induced, to my mind, should have been a relatively sudden worsening in 24-48 hours. Okay.
And sensorium. No, sensorium will be affected by multiple factors including sensory. So I think if you ask very step by step, then you often get a good idea of what kind of illness we are dealing.
Okay. Sure. Thank you all our online viewers. So we see you next time. And now that this system is working properly, please send the message to all the student groups wherever you can, so that more students can benefit. Right? Yeah. Thank you.
Yes.
Okay.
Thank you, sir. Thank you, all faculties. Was wonderful. Thank you,
Those who
students.
have made audio visual so very easily possible. Rajesh is one
No. I think
that.
the whole idea was started by Anjali and Joshi and everybody.
I think Anjali, we must thank you, Hemant and Arsana for, and then of course Rajesh who looks after local arrangements, and now he's an expert on managing everything here. You have been doing a good job for us and we appreciate your help. Thank you.
Thank you so much, sir.
Thank you.
Thank you.
Bye. See you. Bye.
Bye. See you next Thursday.
As always, after 3 days, and now we